Thank you. I don't have any relevant disclosures. I think I should say that, I'm just speaking from experience. I don't claim to be a success in academics, but I've learned a pretty good amount during my short career so far. So when we think about academic surgery, we really think about Halsted, who is the father of surgical training, who introduced us to this triple threat idea that, Justin Dimick just exudes of a researcher, a clinician, and a teacher, and created the modern surgery residency with really the focus on teaching medical students in the ward as being the marker of success. The actual definition of an academic surgeon is just any surgeon who's a member of a medical school department of surgery, who contributes to the intellectual life of the department in any way and is engaged in teaching, research as a physician scientist, program development and leadership, or translational research and innovation. So pretty broad definition of what an academic surgeon can be. Along the traditional model is moving along the alphabet, starting with R's and T's and F's, and then moving to K's and back to R's, along a set line for yourself and your institution and your reputations. With that framework, success could be measured by inputs of research, some clinical production, and really teaching and scholarship, giving to academic achievement and student learning. In that traditional model, you would have some freedom from the private practice pressures that we just heard from Dr. Crawford, taking on the most difficult cases from uninsured patients, the ability to spend extra time teaching, traveling, and presenting like this, networking and promoting the academic excellence of your division and your research, and having different clinical production goals as a result, probably at a decreased salary. But that's not the reality we live in now. The reality we live in now is that the reward system is based on financial viability. It's really important that you know your local environment in order to succeed. When I took my first academic job at Columbia after finishing training, Jerry Marks gave me this article called How to Swim with Sharks that was written in the 1700s from an oceanographer that was related to Cousteau. And then it was given as a talk in the 1970s at a thoracic surgery society. And this is the most relevant thing that has ever prepared me for being in academics. You could read this once a month, and every time it would still be like, oh, he's so right. Most important thing is do not bleed. It really is a cardinal principle that experience shows if you're seen bleeding, it prompts a more aggressive attack, and it'll provoke the participation of other sharks to attack you as well. Current model is more a paradigm shift into unnecessary administrative tasks that can drive you into burnout and push you away from the work that you really want to do. And if you don't meet the traditional model of the academic surgeon that we always think of, you can be hit with pay inequality, aggression, harassment, lack of promotion, and backlash that's very common in most academic institutions. And you have to really love surgery to move through it all. The reality is that there is less rewards available for us as academic surgeons. There's been almost a 70% reduction in our awards since 2000. It's about 700 less awards annually. And the federal funding and academic funding that we do have to support us isn't aligned with the pay that we would make. So it leads to the need for subsidization of our awards, which salaries aren't keeping up with, and our departments may not want to fund, or leading us to find additional awards and foregoing protected time, which is ultimately going to be unsustainable. The inputs have changed for success. Clinical production tasks and administrative tasks have taken the lead of the inputs, where research, teaching, and training are on the bottom. The environment is also a major factor because we are reviewed on that. We're also reviewed on patient ratings, productivity ratings, student learning, and we need to be persistent and resilient in order to survive. And the one thing that we're not so much judged on is our academic achievements. Success from our leadership could be just meeting and exceeding productivity, completing our charts and op reports on time, having acceptable outcomes, patient and student reviews, meeting our CME and program requirements, and not complaining or having complaints come up about you. There's not much focus on our research productivity, presentations, presence, or academic service there. But if you want to advance, that's when these things come up. Advancement and promotion are still primarily based on research and scholarship, where only the numbers matter of publications, your educational portfolio, and your recognition, which is letters and teaching skills. Even though most of our time is going to be spent in clinical work and administrative and program tasks. This is an example of an academic scorecard, which doesn't really align with what we do with most of our time and makes it more and more difficult for the modern academic surgeon to advance. As a result, almost 50% of academic surgeons are leaving their initial appointment within 2 years of joining. Over 20% are going to move to another academic appointment, but 79% move out of academics. And more than 40% meet the definition of burnout and 30% depression. So in order to survive in this, we really have to create our own measures of success in academics, because as you've seen, the measures that we have from our peers and for advancement don't really fit. The main thing is to really know yourself and your own goals. You can't be happy unless you know that. Define your goals, figure out what drives you, what your priorities are, and what makes you happy. List them out succinctly, like these are literally my goals on my fridge. Revisit them, edit them as you need, and figure out how you add value to yourself and your institution. Also know that your job should not be your entire life. You have to make sure that you can participate in family, home life, friends, and social life, or you will burn out. You can do it all, you just can't do it all at the same time. You also have to find the best fitting academic path for yourself. There are still clinician scientists, but you can also contribute in public health, administration, and clinical educator roles. But there was a great article published in 2017 where the leadership at Baylor was surveyed on the common traits among themselves and all academic surgeons, and these 7 really fit with all of those surgery service lines. Identifying complex clinical problems that are thought unsolvable or ignored, being an expert, innovating to advance treatment, observing outcomes to further improve and innovate, disseminating knowledge and expertise, asking important questions to further care, and training the next generation of surgeons and scientists. You also have to choose a job situation where you can succeed. In this, research is going to be prioritized, and the compensation model should reward you. You should have a guaranteed salary for research time, with a lower RVU expectation for it, and compensation provided for grants that you submit, not just that are awarded, because grant submission takes a lot of time and effort. Manuscripts published and national presentations. You should also have proximity and warm introductions to interdisciplinary collaborators. Otherwise, you could spend a year trying to figure out who can help mentor you and work with you and just sending blind emails with no response, as well as a group of trustworthy and reliable partners so that success is met by everyone meeting their individual goals and then the collective goals of the department. In this, success can be measured with the right contract. In it, you should have clear, concise definitions about what your role is to the team. Research time built in, not protected time, that's a fallacy. Research time, without the need to buy it back, because that's code for we don't really support you. Transparency on funding for your research for at least 3 to 5 years, and then what's going to happen afterwards. A defined number of papers, presentations, or grants that are expected of you, and support that is spelled out, including coordinators, analysts, grant management staff, access to databases and data banks, and core laboratory services. You also have to find a leader that supports your success. You want somebody that's going to be in the trenches with you and share your goals, not trying to set the precedent that you can work in your spare time or your research time is from 11 p.m. to 6 a.m. Without a leader that supports your success, you're going to feel isolated, you're going to have a loss of autonomy, an ineffective work environment, problem with work-life integration, and excessive workload that can drive you to burnout. And at that point, a career change is really all you can do. Because let's be honest, you don't leave institutions, you leave bosses. So you need someone that you can work with. In this, success can be measured by a boss that gives you visible roles at your institution, not just busy work, that recommends you for national talks and editorial boards, sometimes even in their place, will stop into the OR when needed and can somehow even sense when you might be needed, and gives bonuses or job-specific perks to you without being unsupported or pushed out. You also have to audit your quality outcomes regularly. Above all, we are technical surgeons and we need to be excellent surgeons. So know the literature in your field and track your outcomes. And the easiest way is with the ACS Surgeon-Specific Registry, because that can also help you when you go for reaccreditation. Quality metrics that are important for everyone are length of stay, readmissions, reoperations, morbidity, and mortality. Those are the basics. But you can also customize with your own value-added metrics like opioid use, ER visits, office calls, and resource use of monitoring devices, and PROMs, which are very important. And here, successes can be measured by comparing your outcome to yourself and to standards every 3 months. And have, baseline numbers like a 5, 10, 15 rule. Major morbidity should absolutely be less than 5%. Readmissions and reoperations 10, and the minor morbidities 15. Regular performance evaluation is also very important. Nick Saban was quoted by saying, "Average players want to be left alone. Good players want to be coached, and great ones want to be told the truth." Great surgeons also want to be told the truth, and video tells the truth. You can upload your videos directly from the operating room. Both your technical and non-technical skills can be analyzed then. So you can edit and annotate them. You can segment them by key step and look at your own workflow analytics, your operating times, and really create an operating timeline for yourself. That can facilitate formal video coaching, and it's ultimately going to help with privileging and credentialing. These are just some basics that can be done with Microsoft Excel. It does take a lot of work to do, and there are multiple commercial companies that can do this. Saves time, it does cost some money, but you can see you can pull cases up for yourself, you can compare by the segmented steps, go through, review the videos, look at your own videos, look at other people's videos, and even get help in rating them. But ultimately, a video scorecard is going to help so that you can see your progress over time. Meaningful analytics by step and procedure, using validated performance metrics against yourself, your department, your peer groups, so you can look at your workflow efficiency, efficacy, and really create a CV for yourself based on your operative skills. And most importantly, is creating a network of mentors and sponsors. There is a difference between them. Mentors are known to advise you, to help you realize what your goals are and push you on how to get there. While sponsors act. They will give you the opportunities, the support, and the ability to actually get your goals met. It's extremely important, and even more important for women, who tend to be over-mentored and under-sponsored. Men are 45% more likely to have a sponsor than women. And if we're put into the environment where we're over-mentored and under-sponsored, it's actually sort of like the shark that's left dead in the water to be attacked. So just keep that in mind. And it's important to have an entire network over time, multiple areas of expertise, multiple ages, so that you can have different inputs and support in all facets of your life over time. And these are a couple of my mentors and sponsors that I just wanted to thank for their support and inspiration. Measuring success here is securing a reliable network and meaningful roles. Learning to say no to unmeaningful roles also, with them having your back to know that you'll be asked again, something I'm working on. And then developing your own mentee network, which for me personally is the ultimate mark of success. These are some of my mentees, and that's just a subtle mentee promotion of them presenting here. So in conclusion, sorry to run over, there's been great changes in the definition of academics and the academic environment. And success is going to require self-awareness of your personal goals. To measure it is finding the right contract terms, leadership that visibly supports you and protects you, auditing your own clinical outcomes, video reviewing your technical and non-technical skills, and having a mentorship and sponsorship network. Thank you. So sorry, Deborah.